that look good? Okay.
Yeah.
I was telling Eileen that this year I don't know that there have been any really dramatic updates in primary care. I feel like there have been lots of small ones. So what I decided to focus on was sort of things that have maybe changed in my practice, and I thought I would, to make it relevant to you all, I picked cases from my Bartlett practice, but that overlap with my changes that I've been making in terms of primary care. My only disclosures, I haven't seen any of the Oscar nominees this year, and I'm not paid by Abridge, which is our current AI scribe, but I think I probably should be. I am definitely in their fan club, and that's why I asked Eileen if that would be a good thing to talk about while I'm here as well. Is in the measurement of lipoprotein a in primary care to assess cardiovascular risk. Lipoprotein a is an atherosclerotic LDL-like particle. It is actually said to be about 6 times more atherosclerotic per particle than LDL, but sort of very similar. And then if you look at cardiovascular events, the way it was actually discovered was from in-stent thrombosis. So when they looked at patients who thrombosed their stents, in general, they tend to have high levels of Lp(a), but they also see that it contributes to cardiovascular disease, and in particular to stroke. So this does seem to be a maybe even more predominant risk factor for stroke. It's very prevalent. It's about 20% of the US population, and if you look at Africa, it's about 30% of populations in Africa have elevated Lp(a)s. And if you look at the AHA guidelines, America is actually somewhat conservative here. The AHA current guidelines say to check it if the patient has had an early history of heart attack or stroke, meaning age less than 60 in their case, a family history of early onset coronary artery disease or stroke, or an LDL that's not responding to statins. And the key there is that this particle, if you think about it, when we look at EPIC, it says calculated LDL. So you know how it sort of subtracts other things and then calls everything left the LDL. So if you have a very high Lp(a), your calculated LDL will be higher, although it won't respond as well to statins because statins do not reduce Lp(a). And then there's also tie-ins with aortic sclerosis and stenosis, so it's recommended to check if you would have a patient with that, particularly at a younger age. Interestingly, we are somewhat behind Canada and Europe in terms of checking this routinely. Their guidelines actually recommend everyone gets checked. And the interesting thing is the level of the Lp(a) doesn't fluctuate. So you only have to test this once in a person's lifetime, and you sort of have their level. And so it is something you can check while someone is still at a young age, particularly if they have a very strong family history, or in this patient where they developed a significant heart disease, maybe out of proportion to what we were thinking in their 40s. There's no specific treatment, so this is part of why the US AHA guidelines don't recommend universal testing, but certainly lifestyle modification is something you could engage in a person to try to help modify their risks. You could certainly put them on a statin to lower the LDL to reduce all their other possible risks. And then PCSK9s do have about a 20% reduction in terms of Lp(a). So they are being used, although may not be lowered as much as you need per se. And then there are trials both at Hopkins as well as the NIH for looking at drugs to specifically lower Lp(a). So hers has actually come down to the 400s on a PCSK9. She's obviously still at very high risk, but this has changed my practice some. I'm certainly thinking more about family histories, particularly family histories with stroke and people who have sort of early onset age. I think many of our cardiologists do check everyone, as do many of our house staff. So just something I think to be aware of thinking about in your practice. New USPSTF guidelines for cervical cancer screening have actually, this is obviously for patients in the general population, and they specifically exclude patients with HIV in their discussion. But they have gone to now primary HPV screening for women at ages 30 to 65 is their grade A recommendation. At younger ages, they are still recommending cervical cytology. This does differ from some other major organizations, but above age 30, they're recommending primary HPV screening every 5 years. And they are endorsing the self swabs. And so that was one thing that I was considering in this case, where I would not necessarily apply these guidelines, certainly not the timing of these guidelines, to our general population. But I do think if you have a patient who maybe has had a lot of trauma or is particularly concerned about undergoing routine pap smears, that this may be certainly an option. Hopkins is a site, I believe, for trying to develop workflows around HPV self-swabs in general medicine clinics. We have not actually gotten self-swab kits yet in the outpatient center, but I think that they're FDA approved now, and I anticipate we will be getting them sometime soon. And this,
Hey,
yeah.
I'm sorry, Gail, it's Jean Keller.
Yeah, Jean.
So yeah, I think for her getting a self swab with HPV would be critical. But if it does come back positive, I have, for women who have issues with getting exams and who need copo, even, particularly copo, we can offer them, doing it in a setting where we can, anesthesia, put them to sleep and stuff.
Yeah.
So we can work with somebody. And if you want her to just come and talk to us, we can talk. We don't have to push anything. So understandably, having a bad experience, or if she has a history of abuse, it can be an issue. So yes, please go ahead and get an HPV test on her.
Love it. All right. And I think if you look at the WHO guidelines for low-income countries, in patients with HPV, in patients with HIV, they have now adopted primary HPV testing. I think that Jean can probably speak more about this, but I think there is increased levels of HPV in women with HIV, and so I think in the US that does lower somewhat the specificity of the testing, and I think that has probably led HIVMA to continue recommending cytology in the above age 30 age group, where they're recommending PAP or co-testing. But I'm wondering if that will change with more data as things come out. So, and I just wanted to make you aware of them. They're quite, I'll say, small font. This is one slide out of 3, and it all is on one page in their guidelines, so it's about 6-point font. But I just wanted to walk you through some of the steps and show you where there's some new additions, so that if you're pre-operating a patient, or if you send a patient to a preoperative clinic and you're wondering sort of why they did what they did, I just wanted to go through some of the new things. So if you have a patient, the first step is really, if they're completely low risk, they could go right to surgery. If it's emergency surgery, certainly they can go right to surgery. Those are unchanged. And then if they're having any acute cardiac symptoms, obviously that would be a do not pass go. Get them evaluated for that. But in our case, our patient passes all of those checkpoints, and then the next step is to use a risk calculator to try to calculate his risk for adverse events. Interestingly, the AHA did not adopt any one particular calculator. I think there was a lot of speculation that they might adopt the AUB has2 calculator, which is one of the more updated and more recent calculators available. But they equally said you can use either the old RCRI, which is now sort of over 10 years old, probably a little bit more than that, the AUB has2, or the NSQIP sort of extended calculator for surgical risk. So they said any of those are fine, and then also look for any extenuating factors beyond what's in those risk calculators, because if you know the RCRI or the AUB has2, it's about 5 questions based on age, hemoglobin, other risk factors. So they're fairly simplified. So they're asking now just to consider any extenuating risks. And one I wanted to point out is actually at the very bottom here is frailty. So they are considering frailty and extenuating risk. And if you notice, it's in the same bucket as some of these pretty severe other things like severe valvular heart disease. So it is a fairly significant factor to consider. And I think for many of our patients, that's probably one to be aware of, building that into your assessment. So the next steps, if you have the patient sort of passing through that, you've done his risk calculation for this patient. If it's a low risk, calculated risk and no modifiers, you can go right to surgery. If they have very high calculated risk, in that case, and any of those risk modifiers, so severe valvular disease, frailty, as I said, any of those other ones that they indicate, that is going to be what they call appropriate team-based consultation. I think you can read that as cardiology. And then they're going to go into more advanced testing, probably with echo and possibly other things. However, if they're in the middle, they have maybe a AUB has to score of 1 or 2, but none of those risk modifiers. Then you're going to get your usual EKG and consider any modifying medical treatment you might want. And then it's your functional assessment. So this part is the same in terms of thinking about the functional assessment for the patient. But what differs is now if you can't really make a functional assessment, for example, my patient can't climb 2 flights of stairs, then in that case, you have the option to add additional testing. So the additional testing now that they're recommending to add at that step would be a BNP and a troponin. So once you have this patient sort of in this, I can't really evaluate his exercise capacity, you can get these additional lab tests. If they're normal, then you may proceed to surgery. If they're abnormal, again, you're going toward multidisciplinary team, I think cardiology consultation here to make decisions about, again, more advanced cardiac testing prior to the surgery or alternative strategies. So I just wanted people to be aware that if you're sending someone for pre-op now, you may get these additional biomarkers, and they may be used to risk stratify what goes on further. And if you are pre-oping someone on your own, and again, if you can't make a very good functional status assessment of them, you could consider adding these and then making your decisions based on this. I think the go-to these days that I try to achieve or try to get access to for patients is the GLP-1 receptor agonists. I'm showing you here just all of the things that, or many of the things that have been looked at in terms of their effectiveness in comorbidities. Definite reductions in A1C for diabetes, an average of about 15% weight reduction for weight loss. For cardiovascular disease, significant reduction in MACE and cardiovascular events, and CKD improvement in progression as well. And then this past year, tirzepatide and OSA came out and is now FDA approved for treatment for OSA in patients on CPAP. And then there's been plenty of studies on looking at effects on MASLD. I don't think we have a definitive trial on that yet that I've seen, but probably in the works. And then osteoarthritis, significant reduction in pain scores in patients with osteoarthritis from the STEP9 trial. And then a little more speculative data is in terms of other substance use disorders. So there's sort of trials, or not trials, but circumstantial evidence coming from kind of large data sets looking at, for example, reduction in presentations to clinic regarding either tobacco cessation or reduction in admissions for alcohol use disorder, for example, that have led speculation in terms of their effectiveness in those disorders, and I think have spawned a lot of studies now in terms of starting to look at their efficacy in those areas. But I think the key this year, I think is for many of our patients, it's sort of how to get access to GLP-1 receptor agonists and sort of what will insurances cover. And so I just wanted to say new this year for both Medicare Part D plans as well as priority partners, they have approved GLP-1 receptor agonist use in patients with cardiovascular disease. I will say it has to be documented prior MI, documented prior stroke, or ABI is less than 0.85. These are the priority partners criteria at least. And so I just want to make people aware that we are seeing coverage for those. OSA also Medicare Part D plans, some of them will cover it for tirzepatide for OSA. The patient must have a BMI greater than 30 and be on CPAP at the time. So those are the times where we're seeing it covered outside of patients with diabetes. All right, so now I'm going to switch gears. I'll take maybe just questions in the chat at the end, but I did want to touch upon the use of the new Abridge AI Scribe. I did sort of an informal poll, and I found that I'm not seeing a lot of uptake in clinics so far, so I thought it might be a good thing to sort of review a little bit on and just kind of give you some of my perspective. I think why use an AI Scribe is many of these benefits have been inferred from use of in-person scribes. So in-person scribes have had a fairly, I would say, 5 to 10 year use prior to the pandemic in internal medicine. And so there's a lot of documented literature about use of in-person scribes. And it's been inferred that with an AI scribe, some of these things will continue. For example, better patient interactions have been documented in the literature, less time in documentation, greater physician satisfaction and lower burnout rates. And in particular, AI scribes are soon to be integrated with clinical decision tools, so things that may prompt you for guideline directed therapy and things like that as you're using them for your documentation as well. So I think for all of these reasons, it's worth thinking about integrating an AI scribe. I like this New Yorker cartoon of I got into medicine due to my passion for typing. And I think if you ask a lot of our patients, what do you see when you see your doctor? I'm sure it looks like this, right? I think we all are trying to multitask and we're all kind of looking over our shoulder. At a good time, most of the time we're probably looking at the screen at times. So. There have not been a lot of studies of AI scribes so far. There have been 3 major studies, or I won't say major. There have been 3 studies so far. They're just so new, we just don't have a lot of data in particular on the AI scribe, but Kaiser offered Abridge to 10,000 of its physicians. Within the first 10 weeks, 3,300 of their docs were using it. And they documented reduced time in their notes relative to in-basket, where they didn't have any changes in in-basket workflow. They didn't report on the exact amount of time reduction per physician, I think in part because they, with 33,000 physicians, had a pretty large range of FTE activity. But they did look at note quality, so they took I think 50 different notes and had 10 physicians rank them among the different domains of evaluation. And you can see that overall note performance did fairly well in terms of most domains. You'll see that accurate, there was a little dip in terms of accuracy away from sort of the best rankings. So there are some hallucinations we'll get into later. And a little bit of dip in terms of thoroughness, and I think sort of sins of omission are one of the things that can occur as well. So we'll get back to those as I walk through this. But in Ontario, they had a smaller trial, but they had full-time primary care providers. So these are physicians who are essentially full-time in clinic. They noted a 3-hour per week work reduction. And 80% of their physicians reported that they would continue to use the AI Scribe long term. And then Stanford introduced the DAX Copilot to 48 of its physicians. And again, median savings time was about 20 minutes per half day, which I think if you multiplied that out by 10 sessions a week or 8 sessions a week would be about the same as what they saw in Ontario. When you look at the, this is from Stanford, so they just surveyed them about whether it improved efficiency, whether it improved quality, whether it was easy to learn, various aspects, and whether they would see people using it long term. Again, the blue is people who were sort of moderately positive or strongly positive. The red is people who disliked it, and so I think you can see it favored, most physicians felt favorable about it. In terms of patient perspectives, I think, again, a lot of, when we used the AI scribe with our residents, or when we used in-person scribes, actually pre-pandemic with our residents, the main thing the residents said was, I can finally make eye contact with the patients and I can finally just talk to them. And I think that patients reflect that as well. In the Stanford study, 70% of the patients said the doctor spent more time with them or felt like they spent more time with them. 80% noted better eye contact. And all of their patients that they interviewed, I think this was 25 odd patients, were neutral to positive about the use of the scribe. Some did report discomfort around sensitive topics. So I think, certainly be aware of that. And some patients wanted that consent to be done each visit. So that's what Hopkins has adopted, is each visit you consent the patient. And I think it's important to tell them, we can turn this off anytime you want, or if there's a part of the conversation that you don't want me to use this for, that's completely fine. But I will tell you, just the majority of my patients, and I've probably used it with over 200 of my patients, I think 2 have not wanted me to use it, and 2 have had times in the conversation where we've turned it off while they were telling me something more sensitive. But the vast majority of the time, patients are quite happy to have us use this, and I think they do feel the better engagement. So why should Bartlett use AI scribes? So I thought I would try to hone this down for you all. This is data from our EPIC system. So if you look at sort of all Bartlett providers, it tells us we're doing 26 minutes of pajama time per scheduled day. So pajama time is defined as work outside of 6 p.m. to 7 a.m. Or weekend time. And this 26, you'll see, is actually a conservative estimate because it's adding in, I think, providers who are not regularly in Bartlett. If you look at sort of regular Bartlett time, in pajama time, we're at sort of above 40 minutes per scheduled day. So if you add that up for your whole week, if you were an everyday provider, you can see that that does add up to a lot. And to kind of give you a graphic of how this appears visually, this is one provider at sort of the 40-minute per scheduled day pajama time. And you can see the colors here. The purple is time in your notes and letters. And you can see during the bulk of the day, you're doing lots of things in EPIC. And at night, you're doing your notes. So I think, this is really, I'm pretty passionate about this to try to reduce burnout, certainly for our residents, but I think also for my colleagues. I think we just can't flap harder these days. We got to really try to see if we can improve some of these workflows. So if you think about sort of what the scribe does and doesn't do, if you haven't used it before, I will tell you it creates a pretty good HPI. It can really follow the conversation and coordinate it. It creates an assessment and plan really based on your conversation, obviously. So if you didn't verbalize a differential to the patient, it is not going to have a differential with it. But if you spent time talking to the patient about what might be causing their neuropathy, it will usually capture a pretty good version of your differential diagnosis. It will certainly capture all of the plan that you convey to the patient as well. And you can also use it to create patient instructions. And I think that's, a part in EPIC that often gets very maybe cut short at the end of our visit, is when we're trying to just type in some patient instructions. It creates better than any doctor I know's patient instructions, and in a very layman's term to give to the patient. So I think that is a big edge for the patients. It does exclude chit chat, maybe a little too much. We'll talk about omissions, but if you have a social conversation, it's not going to include, all of the patient's trip to Florida and things like that. And it can handle multiple speakers. So I've used it with an interpreter, the patient's daughter, and the patient, all speaking different levels of Spanish and English at the same, in the same conversation. And it was able to sort that all out. It handles accents fairly well, and it actually understands 14 languages. So if you were qualified to conduct a Spanish language visit with a Spanish-speaking patient, it would listen and it would create your note in English, which I think is a big advantage. It does not read anything within Epic. So if you're talking about family history, but you did not go into the Epic part of family history and see everything there, it's just going to include what you talked about. It doesn't integrate in any way or pull things from any other sections of Epic. So just remember, it's all your conversation. It will not suggest or should not suggest diagnoses or evaluation for you. So, that will probably be coming, as I said, in the future, but at the moment, it's just going to go from your verbal instructions. And right now, one thing that's unfortunate is even though it can write the note in a different language than it's hearing, it doesn't write. You can't ask it to write patient instructions in other languages, which I'm hoping they will add because that could be a big value for us. The consent process, so remember that recording without consent is illegal in Maryland, so this is a very important part of using it. You do have to go to your My Learning. There's a 1-paragraph thing you need to read, and then you click a box saying that you have read it and you understand the consent process. And you do need to consent each patient and every time you use it. I think other health systems have incorporated it into their general patient consent form that patients sign for care in the clinic, but we're doing it sort of each patient and each visit. I usually tell the patient, we have a new AI scribe. It's going to listen to the conversation and it's going to make a temporary recording, and then it will write the note for us. It saves time and helps me focus. Is it okay to use it? So that's how I bring it up. If they say yes, I say, and we can turn it off, anytime during our conversation that you want. You don't need to consent any nurses or staff who come in, for example, to give a vaccine or to talk to you while they're in the visit. They're considered consented sort of within the hospital. You do need to document the consent. So if you're using your own note template, you do want to include this dot phrase into it so that it will generate a pop-up box for you with each visit. And you just click off who you consented during that visit. And then there's currently, you've probably heard, 2 ways to access Abridge. The easiest one is really through an iPhone and through Haiku. It's a little more work to go through Android or other systems, but I'll show you both of them. And I would say even if you have to go through Android and through a website, you will still probably find significant savings in terms of time. We had to do this in our pilot when we were first testing Abridge, so I know that workflow pretty well. And it's, it's not fun to have an extra step, but it still is a time saver. If you're going through Haiku, you'll just look at your, clinic schedule for the day. Once you select a patient, you'll see an icon down at the bottom that is the Abridge icon. You click on that and you get to a recording screen. And then once you've started the recording, it will look like this, and you can pause it at any point to take a break or go out of the room, and then hit record again when you're ready. And the final step is you hit this create note button, and it will instantly, or within 30 seconds, send that note into the main part of Epic. One thing to know is while you're in the room with the patient and doing the recording, it's not like the notes coming up in real time on your screen. So if you have a particularly long visit, I usually take a few handwritten notes just because otherwise if I haven't created the note yet and I need to go back to something they said early in the visit, it helps to sort of have a little few chicken scratch jots. If you are outside of Haiku, or if you're using it on an Android phone, it'll be a little bit different. You'll have to just register at the Abridge website and download the Abridge app. But the app will actually show your schedule for the day. So this is on an Android phone, you can see your schedule. Again, you click on a patient, get the recording screen, and then you're off and running. However, once you're done with your recording, instead of it automatically importing into Epic, you would then need at the end of the day to go to the website and do a sort of copy all of the note and then cut and paste that into Epic. So hopefully they will work with Android soon to make this as seamless as it is on the iPhone, but right now just be aware of that extra step. Couple things I'll show you on the website, though, that are useful sometimes to have access to is this is the note that it has composed, and then in this panel is your actual transcript of what exactly was said. It keeps this and the note on the website for 30 days after you have had the conversation. So if you think it hallucinated about something, you can just go and highlight the text where you don't recall that coming up, and it will take you to the exact part of the speech transcript. So you can cross-check, what did the patient say, what did I say, how did it hallucinate that, right? And a lot of the times where I've actually thought it was hallucinating, when I went to the transcript, the patient had said something similar and my brain had just edited it out and I was the one hallucinating. But you will see occasional hallucinations. I did see one where clearly a patient told me a skin lesion was black and the text actually said it was white. And when I went to the transcript, it had been a poor audio connection, and I think it had just had a blank in that area on the transcript, and the computer had wanted to fill it in with something, so it had created a color for me. One thing I'll say is if you're starting using it and you're not satisfied with how the writing is, I would go and check the recommended settings. Again, this is through the website. You can adjust your settings, and the recommended ones I would make sure you're on to start with would be the HPI should be comprehensive, but I think most of us have an assessment and plan style that fits more with their concise version, and then a bulleted format. So if you look and you can change these settings yourself. They will also be adding some subspecialty settings coming up, I believe, so it will get probably more nuanced as we go. Just to give you some templates and dot phrases to start with, we have the resident clinic one you are happy to steal if you wish. These have the dot phrases for the HPI section and the assessment and plan section built into them. So as soon as your recording is done and you bring up the note, it automatically integrates those. I'll say this PE sec, I don't typically use that, just in the sense that it's hard to verbalize enough of your physical exam to get it all captured in the note the way we would normally have. So I think a lot of people either still document their physical exam either with sort of macro boxes or just with kind of filling it in. What I typically do these days is I actually step out of the room after I've seen the patient and I just click the record button again. I dictate my physical exam into the Abridge, and then it will create a very nice physical exam if I've dictated it, but otherwise it's tough to get that fully in. And then just to show you an example of the patient instructions, so again, it will, on the website or in Epic, you can get to the section where it has your note and the transcript, and then right here it has a second tab, which is your patient summary. And when you click on that, it will give you, again, a nice little summary paragraph for the patient about the visit. And then it will give the plan by problem list, and then it'll give some composite instructions at the end. And it does this, as I said, I think in a really nice way. will explain about diabetes and sort of, in layman's terms, and give them some more definition than I think we typically have time to type. And then it really does lay out the plan quite well for them. If you're in Epic itself, the way to get to the patient summary, though, is a little bit convoluted. When you're in your note, you'll see that there are 3 little dots, and when you hover over them, it says linked evidence. You need to click on that to get to this screen in Epic, and then toggle to this patient summary. I'm hoping in the near future that this will just auto import into your patient instructions, but right now you need to come here, cut paste this into the patient instructions. So even though it saves a lot of time in the writing, there's still that cut and paste step at the end. So hopefully fixed soon, but that's how you can do it for now. And then I think a lot of residents, and I also hear this from faculty, is the concern that that they think when they write their note. So they're hesitant to use Abridge because it is that composing the note is often where they do their clinical reasoning and their differential diagnosis and things like that. So it is a change in workflow where you need to now do that amount of thinking as an editor rather than as you're composing the note. And I think that is a fair mental switch. I think always consider the AI note to be a draft for many reasons. As I said, it can hallucinate at times. It's usually, I would say the accuracy is very good, but I would not sign off on an AI note without a full read through it. And when I read the HPI, I really try to think about just how did it write the narrative, what got left out. Oftentimes it's the social context, because remember, it is skewed toward avoiding chit-chat in the medical note. So if something's not clearly medical, it may leave that part out, even though that to you that may be a very important social context to include. And then AI tends to be a splitter, not a lumper. So if you talk about something like their back pain, and then you talk about their pain in their leg and their numbness in their foot, it will typically could split those into 2 separate problems or paragraphs rather than understanding that was all sort of sciatica for you. So I sort of sometimes have to merge a couple things, but in general, it does a fairly good job with an HPI. I typically liken it to kind of a 3rd-year medical student. If I had a 3rd year sitting with me and I interviewed and the med student took the notes, I would say does at that level or better without any editing at all. I'll say medications are a very common source of hallucination for it. If it can't understand what a medication name is, it will not leave you a blank or alert you. It will just fill in a new medication that you've never heard of before. So I think I definitely look for all the kind of capitalized things in my note closely and make sure that all of the medication names have been done properly. That is the most common hallucination that I've seen. And then physical exam, I think you just have to be a little bit attentive here, particularly if you're using the .PESEC as your dot phrase. It's going to pull in any physical exam you verbalized, but if the patient mentions something that sounds like a physical exam finding, like the patient says, 2 weeks ago, blah, 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 my foot was red, that foot was red may come up in your PE. So you do want to just cross-check, make sure your findings are there and there's no additional surprises. And then the assessment plan, I think, is really where you need to, obviously, if you have not conveyed your full clinical reasoning and your full differential in your conversation, this is where you're going to need to do most of your editing and put that in. So this part of your writing is, very similar to, I think, kind of de novo composing your note, is you really are going to put your thought process there. I think, again, it will come up with an assessment plan that you can edit, and that assessment plan is going to be about the level of sort of a 3rd-year medical student again. So a lot of the nuance that you have or things you didn't verbalize are not going to be included there, and that's what you just need to build out. This is just to give you a sense of what it does with assessment and plan. This is a recent patient of mine. I talked about gout. This is what it said without any editing, and this is the exact plan that I had verbalized to the patient, and that it was able to capture perfectly. And again, it had it perfectly in her written instructions that I could just print off for her as well. Sins of omission, I think, as I said, is probably bigger than the hallucinating. Is sometimes it can leave things out, and again, mainly things that are socially oriented. But this was the study from the Ontario doctors. They looked at 6 different AI scribes in that study, and you can see that almost every scribe, the same issue came up in terms of the error type, which is mainly omission of lifestyle factors, maybe some parts of the HPI. So filling those in at the end. And then what about bias? I think, this is always a concern with AI systems. I'll say it has not been studied as of yet. The system is trained on large data sets. My experience thus far is that the wording is very neutral, and in general it is more neutral, I would say, than most physicians' notes. So I think it actually does a fairly good job with neutralizing things, but I have seen a couple examples. This is one from Natasha Cheetah. Despite having lung cancer, the patient continues to smoke. So you can imagine a little bit snarky, perhaps, for AI, but undoubtedly of the data training sets, I'm sure that is how it was said multiple times in notes that it was trained on. And then I've also seen a couple examples, for example, in transgender health. It may say things like transition instead of what we might use now to say gender affirming. I think, this is a particular example of where language, I think, is changing or has changed over the past few years. And so I think obviously when it's trained on older data. The forms of usage that we have now may not have been included. So I think just be aware for those. And I think just be very vigilant in areas that may traditionally have bias, and those would be probably the areas where it's most likely to be prone to it. But I think that it'll be interesting to see how the studies are compared to physician written notes, which I think will actually have more bias probably. A couple pitfalls and quirks that I've noticed as I'm working with it. It's easier to lose track of chronic or past problems. So for example, if you're used to copy forwarding and modifying a note, I will say you still probably want to do a copy forward into part of your note, use the .hpi sec to fill in the current HPI, and just merge any things that overlap between the two. And I think that's a good way of incorporating your past problems, and yet having a very nice narrative on the current or acute issues that the patient has. I definitely am very attentive to my problem lists as a way to track those chronic problems as well, but if you're a copy forward person, that's another way, I think you can keep those chronic problems not addressed into the notes. Every once in a while, it messes up on gender and pronouns. I think it makes assumptions based on the pitch of voice, to tell you the truth. So I sometimes, if I have a female patient with a lower voice, that's where I've seen it make a mistake and misgender the patient. But you can change the gender, and you can certainly change it to they pronouns as well, if you wish. I do say consider a lot when I've given a specific plan, like I'm going to refer you to physical therapy. Sometimes it will waffle a little and say consider physical therapy. I just edit those out, but it's a strange quirk. And then we talked about exam findings that might come in. You can always cross-check the transcript, as I said, if you think there's hallucinations, and I think Abridge thus far has been responsive to us giving feedback about when we see problems. I'll say if you need an exact dictation with very precise wording, I would just still use Dragon and dictate that way, because Abridge is meant to be conversational, and so it tends to kind of round off the edges on things like MRI reports where you want to keep all of the exact wording. And then my final tips, I usually give the scribe a one-liner before I start the encounter with the patient. I think it just helps to kind of give it a little bit of the major comorbidities that we might be talking about and set it up ahead of time. If you don't, it's no problem, but I do think it might help it organize it a little bit better. The more clearly, that our communication is with the patient, the better the note's going to be. And in particular, paraphrasing back is very important here. So if the patient has given you a lot of history, giving a wrap-up, paraphrase back to the patient, I think is very helpful both for the patient, but also to clarify keep the note. As I said, I tend to keep a few notes during the visit just because you won't have any documentation until the very end, which can panic you as you realize that you've forgotten something from the beginning of the visit. I do tend to try to explain more of my thought process to the patient, which I think is actually good. But if it's something where I'm not ready yet to have to discuss with the patient, or I'm too uncertain, once you step out of the room, again, you can just turn it back on and sort of dictate into it your differential, and it will incorporate it into the appropriate parts of the note. You can also try to alert it to when social things may be important by adding the phrase, "that's important to your health." So Abridge has told us if we use this as a prompt, I'm so glad you told me about, that your daughter's getting married. I think that's very beneficial for you, and we'll work on, I'm trying to think how to incorporate this. We'll work on, getting you in good health for that, for the wedding. I think it's going to be really important to your health. So if you use that, it might help to tell it that where social things are key. So I'm happy to take any questions on either medicine or Abridge. Let me look in the chat real quick. Are the scribes optimized for clinic visits, inpatient, or both? So that's a great question. It's really come from the ambulatory world, which I'm happy about. You can use it inpatient. Inpatient, you're not going to be able to use the haiku version because you're not going to have the Abridge tab sort of in the patient in haiku. So you do have to use more of the app version for inpatient. It's just being rolled out inpatient, so I'm still waiting to hear all the feedback from it, but it's definitely usable in both.
Gail, I had one quick question on the lipoprotein A levels. So in thinking about how to put it into practice, is it one of these things where, I guess always your risk is reduced by further lifestyle modifications, but is there any like if you have an LPA of 600, is that like having BRCA where like not drinking 2 glasses of wine, how do you weigh those?
Yeah.
Does it confer, since it never changes, does it confer like sort of a risk profile that's unchangeable, or what are the, how do you think about that?
That's a good question. 600 is the highest that I have seen, honestly. And for many patients, you're going to be in the 100 to 200 range. And so I think if you're in that slide, there's sort of it is almost a dose response to the amount of Lp(a). So I think if you're in the 100 to 200 level, I do think lifestyle changes, controlling the LDL, advising people about smoking and all of those things that we do, but now I think you can maybe give it some extra emphasis and is going to be important. So if it's 600, honestly, I think that's equivalent to a terrible hyperlipidemia, familial hyperlipidemia syndrome. And there are, sometimes they even do pheresis and things for these levels. Hers have come down. She hasn't been on pheresis or anything like that, but the other thing is to think about it as a genetic problem, as you said, like BRCA. So informing her children that they should definitely get tested. And I think, for me, that's, I'm not necessarily testing every single person at this point, but I'm close. But definitely if there's a family history of early onset and it's a young person, I think that's the time to test, because it's not like it's something that I think to be aware of, because you're going to have to make major kind of lifestyle changes from early on.
Yeah, no, that's super helpful. And I think also just in weighing in how much you emphasize different, because like often we have to pick and choose like which are the things we're going to really push on in terms of which risk modification. So this is super helpful. So thank you so much. I'm just mindful of the time. This was fantastic. Everyone, this was recorded, so you can go back and watch it again to get the things you missed the first time. And maybe I will actually try Abridge. You are a good spokesman for that platform.
All right. Thanks, everyone.
Thank you so much. Have a great weekend, everyone.